Good afternoon. We welcome you all for today's RDLS session. Today's topic is aging with HIV. Dr. Jaya Chakravarty. Dr. Jaya Chakravarty, ma'am, is a professor, Department of General Medicine, Institute of Medical Sciences, Banaras City, Varanasi. She is also the program director of the Center of Excellence in HIV care and the nodal officer ART Center for BHU Varanasi. She is a national trainer for HIV and has been involved in trainings and mentoring of the ART centers. She has more than 95 publications with 4,971 citations in international and start the session.
Thank you, Shweta. I think the voice has all again gone. But let me just start my presentation. Otherwise, we won't finish on time. So today we'll do a very, very important topic, that is aging with HIV. I hope you can hear me. Yes?
Yes, ma'am.
Yeah, right. So change कर दीजिए. Change में कुछ problem आ रहा है.
Ma'am, click on the slide and then next.
Okay. Okay.
Click anywhere on the screen. Yeah.
Yeah, I did that. So what will the overview of the slides are? First, I'll tell you about the changing trends in the age of the population, age of the PLHIV population. Then we'll take the consideration before treating HIV patients who are aging and manage age-related non-HIV comorbidities, which is very, very important, has become very, very important nowadays. And then just summarize what we have told you. So if you just see this graph over here, just concentrate on the upper blue part of the graph. Here you can see in 2005, those patients who were 50 plus age group was very less. But in 2025, the proportions of people PLHIV who will be 50 plus has increased very, very quite a lot. It's the maximum. Maximum patients will be in the 50 plus group. That is an estimation that has been done. And if you just go back to your ART centers, you'll see that that is true too. So initially, in 2005, most people were in this group, that is 25 to 40. But in 2025, 50 plus people who are HIV positive will be the maximum. Now, does the life expectancy of adults with and without HIV vary? We all know, yes, that is true. If you see the graph over here, the life expectancy of those without HIV is around 67 years, but with HIV, it is around 57, almost 10 years less. And what about those people with HIV who will live with some comorbidity-free years? So you'll see that at the age of 21, around 15 HIV people who are HIV infected, around 15% people will have a comorbidity-free years, while those who without HIV, they have almost 30 years, which is comorbidity-free. So HIV people are more likely to have comorbidities. That is what this graph only shows. So before I go further, what is aging? Who are supposed to be elderly in HIV patients? Now, we all know that definition of elderly in geriatrics is 65. But for HIV, they have all the things that occur in elderly, normal elderly much earlier. So for most studies, 50 years has been taken as a cutoff where we say they are older adults. Okay. Now, you just see that trend. Out of all, this is a study done in 2018. I did not get this full study, but Unison Medicare is, I think, Indian-based study. So here they saw that 55% of those PLHIV who are more than 50 years were those who had grown old with HIV. That means they had HIV before the age of 50 years, and then they have survived this long. But the rest, 45, they were new infections or they have been diagnosed late. So both these are a huge, huge problem because people do not think that people, why their new infection is 17%, because these people maybe they are single, they are less aware, they think they cannot get this infection, they may not know about HIV infection. So these people get newly acquired HIV. 17% of people with age more than 50 years, they get new HIV. And 28% are diagnosed late because the clinicians don't think that at this age the patient can have HIV. People don't do low voluntary testing. So that is why they come late to our diagnosis and care. So I'll just tell you a story. There's a lady just in my ward. She's around 65-year-old, and she has a burn. She had burn around in January. उसे काई कर रही थी, that is very common. And then she got some transfusions, and the patient has came with us with an HIV report which was positive, which in our ICTC was negative, but I decided to do a viral load, and the viral load was strongly positive. So new infection in an elderly due to some, and but good thing is somebody did that HIV test and they came out to be positive. That means it is acute infection. The antibodies have still not, all the antibodies have still not formed. So you should think that elderly or more than 50 years people can also get HIV. So as a clinician, that is important for you. So it should not be that these people are at a less risk. No, it may not be true. So what I wanted to summarize of a summary of the first 3 slides were: any HIV above the age of 50 is considered older adults, and they have most of the comorbidities of elderly who are non-HIV positive, plus they make up a significant group in our ART centers, and that is why this whole RDLS session is very, very important. And they are becoming important because many of our PLHIVs are growing old, but we are still getting new infections in people with this age group, and we are also still diagnosing them quite late. So there are certain considerations before treating HIV in aging, and what are they? What you should know, the top 10 causes of death, whether HIV or non-HIV, has changed from communicable to non-communicable. So what are the biggest killers for everybody? It is heart attack or ischemic heart disease or heart failure or COPD or stroke, okay? And infectious disease like pneumonia, diarrheal disease, tuberculosis, they've taken a back foot. And diabetes is another big, diabetes and CKD are also one of the major causes of death in India. And this is for general population as well as for your HIV positive population. This has changed for everybody. Now, this is a very old study based in 2012. If you just look into the graphs, the number of comorbidities per patient who are HIV negative, this is the blue one. They have the blue people. The blue part of the graph shows those with no comorbidity. So even if you compare at the age of 45 to 50, the risk of having comorbidities is higher in HIV positive than HIV negative. And if you just see as the age grows up, the number of people without comorbidity significantly decreases. And not only that, the people with more than 3 comorbidity, look at that. It becomes the largest as the HIV positive person gets older. So what are the comorbidities that we see? Because we all know hypertension, angina, myocardial infarction, peripheral vascular disease, liver disease, chronic renal failure, so and cancers. These are the main comorbidities which really increases in HIV positive patient. Though this study has been done in Netherlands, I think that if done in India, it will be the same. So the other problem is if you have comorbidities, you will be more likely to take more and more drugs. So polypharmacy, and any drugs you take because you have ART also, they might be drug-to-drug interaction. So again, this again shows you the same thing. So there are very few people as the age increases in people with HIV, the people with no co-medications, they decrease significantly. And you can see the number of people with 1, 2, or 3, or 4, 1, 2, 3, 4 co-medication, they keep on increasing. So managing age-related non-HIV comorbidities, what does it do? It increases, not only increases the expenses, with people who actually after 50, the income usually decreases, the pill burden increases, there's an increasing visit to doctors and labs, and to all the ART medical officers, I would really like to thrust on this. Please ask कि आप कहीं और से दवा ले रहे हैं कि नहीं. Many times they think that खाली यहाँ पर HIV की दवा मिलती है, and they will not even tell you कि वो हार्ट के डॉक्टर से एक दवा लेते हैं, किडनी के दवा से 4 दवा लेते हैं, and एंडो वाले डॉक्टर के पास कुछ और दवा लेते हैं. So ask that, the counselor should ask every time, are you taking any other drugs from any other place? And you will get a very surprising answer. The answer will be yes in most of the things, and there'll be a pill burden of 14 to 15. Another story, that patient was is also in my ward. He's around 62 years, and he used to take 5 drugs for diabetes, and all in lower doses. And he was taking 4 drugs for ischemic heart disease, and now he's come with heart failure and recurrent ischemia. So almost 9 drugs otherwise, and of course his TLD and Bactrim he was taking from our center. So this is the amount of pill burden they have. And all this drug interaction, drugs and comorbidities increase dependence and restrict mobility. So even if you give ART has dramatically decreased mortality in PLHIVs. But even when you give ART and the patient takes ART, we know very well that all-cause mortality, though it decreases, but never becomes normal. If we had come beyond this red line, you can see, then if it was on the left side of the red line, it would have become less like normal people. But you see, in HIV, it never becomes normal. So non-AIDS death, whether it is non-AIDS death or non-AIDS infection or non-AIDS cancer, it does not normalize. So they are more likely to get all this. So everything, the stroke, the liver disease, everything, whether you take ART or not, ART definitely decreases, but never brings it to the baseline. So what are the risks which an PLHIV acquires as the person ages? Well, in the patient perspective, of course, the risk related to gender, some diseases occur in some gender, and the genetics he has inherited from his parents. Plus, these people are more likely to be likely to have hypogonadism, early menopause, so that hormone-related risk is also there. Traditionally, they have a higher risk of traditional risk factors like smoking, dyslipidemia, hypertension, diabetes, as I've already told you. Then, of course, as you age, your income starts decreasing. So poverty, because you're sick, you cannot earn. So that is a patient-related risk which occurs during aging of an HIV person. Plus, there are virus-related risk. That is, if you have any infection, there is going to be inflammation and immune activation, and that leads to a lot of disease. And most of the comorbidities like cardiovascular disease and malignancies, they are related to that. You're more likely to get co-infections, which can again lead to certain malignancies. And there might be some treatment-related risk also, like some ART can lead to osteoporosis, renal disease, and other toxic, and increased cardiovascular disease, increased weight gain, leading to metabolic syndrome. And the ARTs may have some drug-to-drug interaction with any of the drugs you may be taking for other comorbidities. So let's go one by one to all the comorbidities and see how they need to be managed. So first we pick up one of the commonest comorbidities, that is diabetes. So the risk of having diabetes in an HIV infected person is 1.2 to 2 times higher. And the prevalence of impaired glucose tolerance is around 18 to 35%. That's all study based actually. That is a study based in India, published in 2017. And frank diabetes was seen in around 9% of the population. And this is a very old study in 2009. If you're just trying to diagnose diabetes by hemoglobin A1C, then you should know that hemoglobin A1C underestimates glycemia in HIV infected persons, which suggests that that may not be the best way of diagnosing hyperglycemia or diabetes in a patient with HIV, and blood sugar fasting may be better. So diabetes screening and management, how do you screen? You do a fasting glucose. If the fasting glucose is more than 126, it's frank diabetes. It's if it is between 100 to 125, it is impaired glucose. Either you can ask the patient to do a lifestyle modification and repeat it, or you can go for a post-meal oral glucose tolerance test. And I told you before also, hemoglobin A1C, it's not a good way of diagnosing, not for anybody actually. See, because whenever as a clinician and you start therapy, you just see ki fasting kitna tha, and the first, and you start your therapy, and then you try and monitor and bring the fasting below 126, and then work on the PP. That is how people manage diabetes. So that is why this is fasting blood sugar levels are a better way of diagnosing diabetes. Then once you have diagnosed diabetes, so first, when should you screen? You should screen every 6 to 12 months. And once you have started the patient on the therapy, then it is a clinician's purview. We usually do it at day 15 and then see whether the blood sugar is come down or not. Then if not, then increase the dose. Again, do it after day 15. If you cannot call the patients so fast, you can at least call them at 1 month. Okay, and then once it is stable, you can just monitor it 3 to 6 monthly. So for those who do not have, if you have to screen for diabetes, you have to do a fasting blood sugar every 6 to 12 months. And if you've changed the therapy, especially those which are known to cause hyperglycemia, like PIs, like lopinavir, ritonavir, and others, then you have to do it 1 to 3 months after starting or modifying an ART. Of course, it is up to the clinicians. And the goal is to keep the blood sugar fasting blood sugar between 100 to 125. And the hemoglobin A1C, this is a very, very loose control. This control depends upon which category of people you're dealing with. If it is young, I would like to keep it below 6.5. And if it is elderly with lots of comorbidities, then we will keep it around 7 between 7 to 8. So does your drugs have interaction with some anti-diabetic agents? The answer is yes. DTG has a very significant, it increases the dose of metformin. So you should not give metformin more than 1 gram in people who are taking DTG. That should be remembered. And other than that, you do not have much interaction with the currently used drugs. The PIs have a lot of drug interactions. So if you are giving atazanavir or darunavir, then you should look into this. Mostly you use a lot of glimepiride. The darunavir can decrease the levels of glimepiride, and it can increase the levels of pioglitazone. And we use nowadays a lot of SGLT2 drugs are used, mainly dapagliflozin and empagliflozin. So these are neutral. So you need to have this as a ready reckoner. DPP-4 inhibitors are also used, but you see, we don't use a lot of saxagliptin. We usually use a lot of sita and vildagliptin, and this does not have, the green ones does not have any drug interaction. So the sulfonylureas have a lot of interaction with PIs. So you need to look into that. Even among PIs, the atazanavir is better. It does not have a lot of interaction, but darunavir, which is used for third line, it does have. Okay, even lopinavir, it does have a lot of interaction with sulfonylureas. So maybe you can opt for any of the other group of drugs. Okay, so Now we come to the second non-HIV comorbidity, that is cardiovascular disease. Now, with the increasing longevity of PLHIV, naturally the prevalence of cardiovascular disease has also increased, because age is a risk factor for cardiovascular disease too. And all PLHIV has 1.5 to 2-fold increased risk of cardiovascular disease as compared to non-HIV people. But they have a very, very high 4.5-fold increased risk of sudden cardiac death. And a recent death has occurred, some of you might be knowing, in a meeting of PLHIVs along with the, I think it was NACO. So, and not in a very elderly, he was only 52 or 53 years old. So this thing you need to remember, they have a very high risk of not only coronary artery disease, but sudden cardiac death. So the relationship between cardiovascular risk and in HIV and HIV treatment is U-shaped. So initially there is sudden decrease in risk of cardiovascular disease when you start ART, but as time goes, you have the risk increases. Why? Because you're aging, you have more and more of traditional risk factors like smoking, hypertension, diabetes. You have persistent inflammation because you do have a virus at a very, maybe at a very low level also, but there is virus and there is persistent inflammation, and maybe some of the drugs may be increasing your risk of cardiovascular disease. So this is a metabolic syndrome. What is metabolic syndrome? It is any 3 out of any of these 5. That is visceral obesity. In the next slide, I'll just tell you what it is. Insulin resistance, hypertension, high triglycerides, and low HDL. If a person has any 3 out of this 5, they're supposed to have a metabolic syndrome because they go hand in hand. So if you see any of the American guidelines, the waist circumference for them is 105 centimeters for men. For Indian, it is 80 centimeter in women. That is 31 size jo aapka aata hai, 31, and this is 35 for men. I'm just making it simpler. See? So if you have central obesity, that is part of metabolic syndrome. And if you have insulin resistance, that is your fasting glucose is between 100 to 125. Okay. Even if you are on diabetes, you come under this. If you have diagnosed diabetes, then you come under this. If you have hypertension, that is blood pressure more than 140/90, or you are being treated for hypertension, you can come under this category. And if your triglycerides are more than 150, or you're being treated for that, or your HDL is less than 50 in females and 40 in males. So if you have any 3 of this, just remember these people all these 5 things go hand in hand. Okay. So if you have visceral obesity, you're more likely to have insulin resistance, you're more likely to have hypertension and high triglycerides and low HDL. So, and vice versa. Okay. So if you have any 3, that is metabolic syndrome. And metabolic syndrome leads to higher cardiovascular death. So how do you identify those at risk? You should know what are the traditional risk factors for cardiovascular disease. Of course, in top comes diabetes and hypertension, dyslipidemia, obesity. For us, obesity is 25 kgs per meter square, not 30. And I told you the waist circumference is 90 and 80. Physical inactivity, tobacco use, excess alcohol consumption, unhealthy diet and nutrition, and family history of cardiovascular disease. So not only in HIV, non-HIV people also, you'll find a lot of Indians are coming into these traditional risk factors for cardiovascular disease. So that does not change for PLHIV, it's the same. Just this I wanted to mention, this is 25 and this is different. For Indians we have a thrifty gene, so we are thin fat, okay? So we think they are thin, but our waist, we have a big abdominal obesity, and that puts us at a high risk of cardiovascular disease. So this assessment should be done at the time of registration, okay? Because at the time of registration, patients are more likely to listen to you better, okay? And or at ART initiation, and at that point you can put this important things in their mind. These are the risk factors. you need to change your lifestyle. And then at every 3 to 6 months and every 6 months thereafter. So you ask for a history, whether you have a history of heart disease, stroke, diabetes, or hypertension, okay, or any history of angina, breathlessness, numbness or weakness of limbs, that is diabetic neuropathy, loss of weight, increased thirst, polyuria, all these are symptoms of diabetes, or puffiness of face, swelling of feet, passing blood in urine, that which denotes CKD. CKD, it has not been mentioned in the previous risk factors which I told you, but CKD is a independent risk factor for cardiovascular disease. So the patient on current and past tobacco use, alcohol consumption, type of lifestyle, history of premature heart disease or stroke in first degree relatives. These people are also at a much higher risk of heart disease. And you should assess the BMI and waist circumference, measure the blood pressure and signs and symptoms of diabetes, examine for signs of pitting edema, murmurs, vessel cramps, the patient is whether the patient is on failure or not, okay? But you should know heart failure is now 2 types, preserved as well as decreased ejection fraction. So life has become much more complicated. And lipid profile if available. So it is better in elderly, in any PHIV with above 50, you should do at least 1 lipid profile yearly, if possible. Then management, lifestyle modification is for everyone, not only PLHIV, anybody who has any of the risk factors, especially for PLHIV because they are more higher risk. You should use a lipid safe if anybody has a cardiovascular disease. So you have to use drugs like avoid abacavir, which is associated with elevated risk of cardiovascular disease. You need to manage metabolic syndrome and diabetes properly. Remember, I said you can give metformin only up to the dose of 1 gram if you're using dolutegravir. The rest you can give most of, but you should be very aware if you are giving atazanavir, if you are giving PIs like lopinavir and darunavir. There you have a lot of interaction with sulfonylureas. And lipid lowering therapy. Well, I will tell you a little bit about that in my next slides. Okay, so you can remember this. This will help you in telling what, but you already know this. I won't repeat it. Be more active, avoid tobacco, eat healthy. So, and that is true for all of us sitting here. We should be doing that too. Okay. So, well, here it just shows even if you give lifestyle modification is one thing that dramatically decreases the incidence of metabolic syndrome. It is much more than metformin or doing nothing at all. So lifestyle modification needs to be trusted every time the patient comes to you. Avoid tobacco, be more active, eat better. I think Indian needs to be told, eat better, okay? Because we are drowning in maida and maida products. So about the management of replace to lipid safe ART. So if you can just see, the ones we use are in the blue lines, TDF and TAF and DTG, they are all lipid safe. The ones that are not lipid safe are the PIs, which I've already told you. And abacavir, it has been seen that in patients with cardiovascular disease, it is better to avoid abacavir because it may increase the risk of cardiovascular disease. For the lipid, I put this slide because this was an excellent study, which was published in NEJM in August 2023, where 7,769 PLHIV with low to moderate risk of cardiovascular disease. In my next slides, I'll tell you how to calculate low to moderate risk of cardiovascular disease. So in this group of people who did not PLHIV, who had a low to moderate risk of cardiovascular disease, who were receiving ART, they were divided into 2 groups. One group which received pitavastatin, which is a statin, and the other group just got a placebo. And it was seen that PLHIV who received pitavastatin had a much significantly lower risk of major adverse cardiovascular event than placebo. up to 5 years. So after this, there has been a change in certain guidelines. The US Department of Health and Human Services, DHS's guidelines have changed in February 2024. They said in PLHIVs with age 40 to 75 years, even when your 10 years risk of ACVD or cardiovascular risk are less than, it is between 5 to less than 20%, you should give a statin. And the trial was done with pitavastatin, but many of us do not use a lot of pitavastatin, though it is available in India. So, but you can give a atorvastatin also, though the level of evidence has gone down, or rosuvastatin. So, why atorva and rosuva? They have very little interaction with other ARTs. That is why they've chosen. So, this is the guideline. So, all PLHIV, even with low to moderate risk of cardiovascular disease, should we give it statin? Okay. You can choose between pitavastatin, atorvastatin, or rosuvastatin. So this is the new guidelines. WHO has not adopted. That is why NACO has not adopted. But if a patient can afford, and I've told my ART center, if medical officers, if the patient can afford, please give. This saves lives. Okay. So I will not go into this. So now all this will become defunct. Okay. Because now usually this is a course in medicine. Like who are we supposed to give non-HIV patients? Who are we supposed to give statins to? Anybody with diabetes above the age of 40 years, anybody with a LDL more than 190, or they have a moderate to high risk of cardiovascular disease, and the risk is calculated. There's a slide after this. So there's a risk calculators which are available free online. But for you, life has become simpler because now the guidelines will change. WHO will also adopt. And when a WHO adopts, NACO will also adopt this, that male HIV above the age of 40 years, they have a benefit if they take statins. So does the statin or the fibrates which are used for hypertriglyceridemia, do they have interaction with the drugs we are using now? So they do not have much with tenofovir or DTG, but again, they have a lot with the PIs. So most of the statin levels are increased with PIs. So you have to just decrease the dose of statin. So if you are giving 20 for these patients on TLD, I think you'll just give 10 atorvastatin in those with PI-based regimen. Okay, so you need to remember this. So lipid-lowering therapy, the statins are the drug of choice, always the drug of choice. Okay, and fibrates are only added if the statin did not decrease the triglyceride level. Only then fibrates are added to statins. So because statin is the only drug which has shown 44% reduction in cardiovascular death, not fibrates. So you use statins even for hypertriglyceridemia, and if it does not come down, then you can add a fibrate to statin. Okay. So I already told you the guidelines. Now statins have different doses. So this is a moderate to high dose of atorvastatin. The moderate doses around 20 milligram is also, this is the high dose of atorvastatin. 10 to 20 milligram is moderate dose of atorvastatin. And that is what has been prescribed by DHSS. And I think the guidelines will change. So this is the most important thing or most new thing that has happened recently. So this is your ACVD calculator. You can calculate the lifetime risk, ACVD risk, which is very high in this case, of course. And if you put in all the parameters, you can put others because we are others. We are not white or African American. And then you put the blood pressure, and you have to do a lipid profile to use this. Okay, this can be only used if your age is above 20. Okay, the age must be between 20 to 79. So you put in all the parameters, and at the end you will get your risk score, lifetime ACVD score and 10 years ACVD score. This is 10 year, and the lifetime risk is 69% and 10-year risk is 17.7%. And that is also quite high. Okay. So we come to another comorbidities, which is very less talked about and is very, very common. That is osteoporosis. Since our PLHIV is aging, we need to think about osteoporosis because these people have hypogonadism. I told you before also, they smoke and they have alcohol, which can lead to osteoporosis. But they can vitamin D deficiency is very common in Indian population in general. Plus, you may have certain hormonal disbalance, which can lead to osteoporosis, as well as co-infection with hepatitis C, which can also lead to osteoporosis. And certain ART like tenofovir, can cause not only osteoporosis, it can also cause osteoporosis and fractures, but certain PIs as well as tenofovir-based regimens can cause avascular necrosis. And if you ask me, we are seeing a lot of avascular necrosis in patients on ART for a long time, whoever used PI or now or on tenofovir-based regimens. So if somebody says pain, let's not ignore that pain. That pain may be important, maybe especially hip pain or back pain. So I think that needs to be investigated. Okay, because if you don't do an X-ray, you will never know of the bilateral hip joints, you will never know whether there is avascular necrosis or not. So, and you will be hampering the treatment and management of that patient. So, all pain is not functional. So, please take care. Okay. So, PLHIV has 6.4-fold increased risk of low bone marrow density and 3.7-fold increased risk of osteoporosis. Okay. Now, they are multifactorial. So this is just a graph which shows the fracture prevalence in PLHIV, the yellow ones, mustard ones. So it is much higher than general population. And as the PLHIV ages, this gap becomes wider and wider. Okay. So as compared to non-HIV people. So what is the prevalence of osteopenia in HIV, in ART, naive? It is around 67% overall prevalence, 70% of osteopenia and 29% of osteoporosis. In ART, experience 80%, out of which osteopenia is there in 63% and osteoporosis is there in 36%. And that's quite a big number. Okay. So, and it is the tip of the iceberg, because I know sitting in the ART, none of you think about osteoporosis, and many of you may not have a DEXA scan in your setup to actually diagnose osteoporosis properly or osteopenia properly. So, though it costs a very, very less amount. So, what should you do? Actually, for any person, PLHIV above the age of 40 years, you can just calculate the FRAX score. I'll show you the FRAX score in the next slide, but that also needs a bone marrow density BMD done before you can actually calculate the FRAX score properly. Okay. So for me, if you had asked me what would have been best, so do a DEXA scan here only. Okay. So if you have a FRAX score actually estimates your risk of having a fracture, it includes bone marrow density or DEXA scan report, but and categorize people into low risk, that is less than 10% risk, 10 to 20%, that is moderate risk, or high risk of hip fracture. So if you have a high risk of hip fracture based on your FRAX score, so you should consider bisphosphonates. That's the best drug. You can give oral, but if the patient has a lot of GI problems, you can just give an IV. So we prefer zoledronic acid because we know the patient are already on so many pills, and you're just adding another pill which needs to be taken in the upright position with lots of fluid, and the patient cannot lie down. The patient should not have any GI problems like gastritis or esophageal varices, or etc., etc. So bisphosphonates are the drug of choice, and you can give it IV single dose in a year, and that makes your life much more easier. Okay, because we don't see the patient do not come to us that frequently. So that is our choice. But you can also give oral bisphosphonate, and that is the guidelines. Like they say give oral bisphosphonates, or if they cannot tolerate oral bisphosphonates, you can go for a IV bisphosphonate, that is zolinuric or zolindronic acid. If your risk is of frac score is in a moderate risk or a high, moderate risk of having fracture, and your T-score based on your DEXA scan is less than 2.5, you should definitely give bisphosphonates. And if it is more than 2.5, again, you can reassess the patient. You can do a DEXA monitoring, and moderate to high risk, many people will give bisphosphonates because they are at a higher risk for fracture. And if it is lower risk, you just reassess every 2 to 3 years. But for all people with osteoporosis, please ensure that you have a lifestyle modification which includes exercise, because exercise makes your bones healthy. They have adequate calcium and adequate vitamin D. Okay. So DEXA scan monitoring, I do not know how many people have it, but most medical colleges should have it. So at least the medical colleges should get a DEXA scan. And this is how often you should monitor. If your T-score is in between -2 to 2.49, then yearly. Then if it is -1 to -1.99, then every 5 years. But don't forget the lifestyle modification and calcium and vitamin D. So this is a frac score, how it can be calculated. You have to choose the country. You can choose India. It is there free. The app is free of cost. You can just go into your mobile and just type it. And though you can calculate without the VMD, but this gives a much better calculation. Okay. So this is how you need to calculate it. And the best thing is to get a DEXA scan. That helps you a lot. So who are you? From here, you can know that who are at higher risk of osteoporosis. Those who have a previous fracture, parents who have fractured hip, if they are smoking, if you are on steroids, if you have RA, or if you have you take a lot of alcohol. Okay. So management of osteoporosis, of course, lifestyle modification, and I have already told you what needs to be done is to give ART, which is safer for bones. And what are they? Not tenofovir. So you can change tenofovir to abacavir, or TAF. TAF is not available in the program, but abacavir is. And change the PI-based regimen, if you can, to DTG. And if you cannot, then atazanavir has better, it is more safer than other PIs. But it is better to change PIs to other drugs. Okay. So this is, you already know this, that tenofovir-based regimens, they cause more bone loss than anything else, than other ARTs. So bone marrow density is significant loss. There's a significant loss both in the lumbar spine as well as hip if you take tenofovir. So if you just see whether it is better to change to zolinronic acid, which is a bisphosphonate, which is given injectable, and versus switch changing from tenofovir. So percentage change with Zolendria is much, much more. So you change to from tenofovir and add a Zolendria, and that changes in your BMD. That causes a lot of betterment in your bone marrow density. So treat rather than not treat osteoporosis, and change drugs from tenofovir to abacavir and PI to non-PI based regimens if you can. Okay? But better to treat rather than not treat. So a word about osteomalacia and osteoporosis in people with HIV, both can occur together. Okay. So osteomalacia is what? That is vitamin D deficiency. A patient comes with a lot of bony pain, and later on you may have proximal muscle weakness and waddling gait, but pain and aches will be a major problem. And the risk of fracture is there in both osteomalacia and osteoporosis. So both needs to be treated well. Okay. It can also cause osteopenia. And metabolically, or the calcium phosphates are decreased, the alkaline phosphatase is increased in osteomalacia, and your vitamin D levels are decreased, and PTH is increased because your vitamin D levels are decreased. So this is how osteomalacia is diagnosed. But osteoporosis is not diagnosed that way. It is diagnosed by DEXA scan. And some people with osteoporosis may have mild to moderate vitamin D deficiency. But osteoporosis is usually does not come with a lot of pain and all. Many a times the patient may be just asymptomatic. Or if there is a fracture compression, then you can have pain. Okay. Deficiency as well as osteoporosis, both are should not be confused. So vitamin osteomalacia requires only vitamin D, and osteoporosis requires calcium, vitamin D, as well as bisphosphonates. The other drugs like teriparatide and denosumab, they've not been used in a lot of HIV patients, so experience is less. That is why they're not that recommended. So bisphosphonates is the drug of choice for osteoporosis in HIV patients. So now if you're going to give a lot of calcium and vitamin D, you need to be worried about dolutegravir. So because dolutegravir has interaction with calcium and iron, as you already know. So DTG can be co-administered with calcium and iron supplements if taken with meal. But if you've not taken the DTG with meal, then DTG should be given 2 hours before or 6 hours after iron and calcium tablets. So remember this. This is important because DTG does have a lot of interaction with calcium and iron. So with food, they can be taken together, but without food, it either has to be taken before or after these supplementations. Remember this. This is important. A word about renal disease and hypertension. So the risk of new onset kidney disease increases with your increasing BMI, smoking, hypertension, age, and diabetes, plus HIV. In HIV, besides all these, it can be due to drug use, tenofovir can cause that. Drugs like PIs, some PI can cause interstitial nephritis, also like lopinavir, a little bit atazanavir. And you can have HIV-associated nephropathy, where a lot of protein goes in your urine, which is thankfully very uncommon in India, but can occur. Okay. So, per se, HIV people are more at higher risk of having chronic renal disease because they have all the traditional risk factors along with HIV-associated risk factors. So, you should calculate the risk. The risk of kidney disease is less if your eGFR, which can be again calculated, is more than 90, or urinary protein creatine ratio is less than 200, or your age is less than 50. As your age increases, GFR decreases, or if you have diabetes or Hep C, hypertension or cardiovascular disease, your risk of kidney disease also increase. The best way of screening is doing a serum creatinine, and do a routine urine microscopy where you can look for proteinuria, sugar in your urine. So that, because tenofovir can cause proximal tubular dysfunction. So that can be seen by if you do a urine routine microscopy along with serum creatinine. Okay. So anybody with high risk of kidney disease, avoid nephrotoxic drugs, which I've told you. And all the NRTIs, including lamivudine, require dose adjustment. The only exception is abacavir. Okay, so you can use abacavir. But usually what we do in our ART center, we change to PI-based regimens because PI does not require renal dose modification, and DTG or dolutegravir also does not require renal dose modification. So life becomes easier. But few studies have shown that abacavir, along with the high dose lamivudine does require dose modification, but there have been case reports which show that even if you take a high dose of lamivudine, because lamivudine is so well tolerated, PHIVs do well with it. Okay, but please don't take it as a word of mouth, but more studies needs to be done in that area. So we change our patients on CKD to dolutegravir plus PI-based regimens, though they become at a higher risk of interstitial nephritis. So then also you need to actually monitor the creatinine, and if there's an acute rise of creatinine after starting any of these drugs, PI-based regimens, you need to stop that. So non-AIDS malignancies. Now, the government already does cervical cancer screening, And we should follow the same rules because we know that HPV-related cancers are much higher in HIV patients. And the government of India actually recommends visual inspection with acetic acid. But now WHO recommends HPV-based testing for cervical cancer screening. But anyways, we will go with the government, what government is already doing. So cervical cancer screening should be done for all female PLHIV above the age of 18, or if they are having sexual activities at the ART initiation, and repeat screening within 3 years if the initial test is negative. And women who have been treated should receive follow-up screening at 1 year. So VIA is a modality of choice for India. But I think in future, India will also adopt HPV testing because it's become cheaper and very easy. You can take a self-taking samples. You do not need a gynecologist to do a VIA. Okay, so VIA, you need to send the patient to gynecologist, which I know in ART center becomes very difficult. You send them to any other OPD, they will not reach there at all. Now, breast cancer screening is a self-screening and clinical breast examination. So this should be done for all women above with PHIV above the age of 30 years at ART initiation, and every 1 to 3 years. You can take out a photograph of this and tell them this is how they need to screen, and this is how you also need to palpate the breast to look for any breast lump. This should be done for all patients, not only HIV patients. Screening for oral cancers, because tobacco chewing, especially in this part of the country, is very, very high. So all PLHIV above the age of 30 years, it should be screened using oral visual examination and at regular visits for tobacco chewers, and at least annually for others. Okay. Now this is a one underestimated cancer which is so prevalent, and even in our medical college, we had a staff in our medicine department who had this and did not come to us, did not tell us, and it had already spread when we came to know, and he died within 2 months. So this is a missed diagnosis, which can easily be done if you just take that much care. Another much less talked about, but a very prevalent condition in HIV patients is mental health. Because they already have stigma, rejection by family, financial insecurity, and over 50 to 75% of study groups of older adults with HIV has shown depression in studies, and depression leads to non-adherence, and non-adherence will again lead to a vicious cycle of ill health and more depression. So we need to screen for depression at the time of initiation and every 6 months thereafter. You just need to ask whether the patient is feeling down, hopeless, depressed. Okay. During the past 2 weeks, have you often been bothered by little interest or pleasure? There are Hindi questionnaires also. You do not need to ask English questions. So for depression, there are Hindi questionnaires in the net, so you can ask those questions. Do ask, because there are such good drugs now. Okay? We no longer use efavirenz, but these patients do need a lot of counseling, a lot of stress management, exercise, keeping yourself busy, connecting them to PLHIV networks and medications. All of them we've done together to help these patients. Okay. Now, frailty. Now, frailty is a condition which usually occurs in geriatric care. Okay, like more people with more than above the age of 65 and all. But in HIV, frailty is very common. You see a lot of HIV patients. If you just see the criteria of frailty, whenever people give you criteria, it means there is no definite definition. That is why they are criteria. So what is frailty? If you have 3 out of any of these 5, unintentional weight loss, self-reported fatigue, low physical activity levels, weakness measured by hand grip strength, and slow walking speed. So they are very non-specific, but if you have any 3 out of 5, you are supposed to have frailty, which is very common in geriatric care. But in HIV, PLHIV, even above the age of 50, you can, all patients above the age of 50, you should look into this. A lot of patients who come to the ART center may be having signs and symptoms of frailty right when they're at a much, much younger age. So look for it. So as you see, compared to non-HIV infected, HIV positive people have much higher, significantly higher risk of having all the 5 conditions which constitute the frailty. Okay. So because the frailty encompasses a lot of physical, social, emotional, metabolic, cognitive, and sensory parts of a person, you need to work on each and every one of them. So you should advise regular exercise, balance and flexibility training. You should connect them to self-help groups, look into their emotional health and metabolic health. If required, you need to put some nutritional interventions, okay, and good interactions with peers and family. All this will help in reducing frailty in PLHIV. So there are a lot of things to reduce this comorbidities in HIV patients, which is beyond drugs. A lot of things you can do. You don't have to prescribe drugs for everything. So you should improve the nutrition, increase physical activity, involve the patient and family and caregiver as well as support groups, and look into the mental health of the patient and see that they don't have to come to the multiple health visits. That is also very depressing. If I have to go to the doctor 10 times more than a month or whatever it is, multiple times, I may not like it. None of the patients will like it. Okay. So what we need to do as ART medical officers and people treating HIV patient, help this aging PLHIV to age with grace. So look, widen your management focus. You're not there just to write ART, TLD, and Bactrim. Yes, no, you're not there. See, a simple MBBS person also can treat hypertension, diabetes, okay? If not osteoporosis or mental health, but you can always refer them to the right places, okay? So strengthen our screening strategies. That's a big focus for NACO. They had a meeting last year in around September regarding non-communicable diseases. Because our ART center should be a one-stop shop as far as possible. Okay, of course, it may be difficult for you to do a pap smear or look in and do a VIA at the ART center, but you should have very good linkages also, because the PPT-CT centers are also linked to you. I know it is not easy for patients to go to another OPD where we have to stand in a line. Our HIV patients do not like standing in line at all. So, but you should focus on the lifestyle. Tell them what is needed. Okay, optimize ART so that they do not complicate the underlying disease further. Okay, if possible, vaccinate them. Vaccination for HIV is another topic altogether. And listen to them. Maybe they are trying to tell you they have some problems. Just don't say कि अच्छा सभी को दर्द होता है. दर्द का दवा लीजिए. Listen to them. Maybe they're saying they may be having osteoporosis, they may be having osteomalacia, they may be having fractures for that matter, avascular necrosis, okay? Or they may be just having some mental illness. So listen to them. That will help them. I know when you have an OPD like we have of 220 HIV patients coming every day, it's difficult to listen to every one of them. But ask your counselors also to help you out in that. If the patient has certain issues, they should come to the doctors, because that will help them to resolve their issues. So these are all your, you'll get the slides so that you can look into the drug interaction, which the drug to drug interaction, if you are giving certain drugs for comorbidities. This shows you how to do an EGFR measurement, your FRAC score, your cardiovascular risk scoring. But I told you now your life has become very simple. You do not have to do a cardiovascular risk score, because you know that statin benefits PLHIV above the age of 40 years. Okay. So these are the tools given to you that can help you in your day-to-day practice. So I think I've spoken non-stop for 1 hour. Thank you so much for your patient hearing. So if you have any questions, I've opened the chat box. You can type it out down there. I can take them up.
Thank you so much, ma'am. Any questions from the participants? Please feel free to type it in the chat box, or you can even unmute your mic. Mic access has been given to all. Any questions on NCDs?
So most of the district hospitals will be running an NCD program, okay, because they are running it. I know that. I do not know about the medical colleges. The state medical colleges may be running it. BHU is a central government. We do not run a lot of NCD clinics. So drugs for hypertension, diabetes are given free of cost. So try and link them a patient up with these schemes, especially those who cannot afford to buy diabetes and hypertension drugs. Okay, so that can definitely help. And I told you about pap smear. Women with HIV needs pap smear. Link them up. I know it is difficult. Gynae outdoor is always very busy, but once in a while they can go. When you tell them this is for them, it becomes very easy. Maybe government is going to bring HPV vaccine. So with that, maybe we'll have the adolescent and the young HIV patients will definitely benefit. But we still have a whole lot of aging HIV. So we need to look into that.
Oh, ma'am, I don't think there are any questions.
I think they've all gone off to sleep. Let me ask some questions then. Should I?
Yeah, please, ma'am.
No, I was just bragging. So, yes, there's one chat. Acha, that's just thank you. So, no questions. So, any of you give bisphosphonates in your practice? You can just type yes or no. For osteoporosis, do you all give bisphosphonates? How many of you have a DEXA in your medical college or district hospital? DEXA scan? Anybody has a DEXA scan? Nobody in the chat box? Yes or no? खाली इतना ही टाइप करना था. So let me see the participants. So Gorakhpur, do you have a DEXA? Saurav, are you there?
पार्टिसिपेंट्स माइक अनम्यूट कर सकते हैं. स्क्रीन पे आपके लेफ्ट हैंड साइड पे बॉटम में एक माइक का आइकन है. उसको अगर आप क्लिक करते हैं तो फिर आप बात कर सकते हैं. यस.
DEXA scan. Anybody, because I've told you about osteoporosis and management. प्रयागराज, आपके पास DEXA scan है आपके मेडिकल कॉलेज में? सॉरी, फिर से बोलो, हाँ या ना? I can't hear you. Prayagraj.
Oh, ma'am, there's one response in the chat box from Neha Dubey, ma'am. They don't have a machine.
That's what I was wondering. I think BHU ART center, so you can respond. You have a DEXA scan. Please respond. So I think we have, but many people do not have a DEXA scan. So the osteoporosis, basically diagnosis becomes very difficult. But other than that, creatinine and routine urine, you can do. Okay, and a lipid profile, most people can do. And a blood pressure or sugar testing, so you should do. So look into sharing now.
Yes, ma'am. Thank you so much for facilitating this session. Thank you for sparing time.
Thank you.
Yeah, thank you, ma'am. We'll try to regularize the RDLS sessions now, ma'am.
Okay.
Yeah, we'll coordinate soon. Thank you so much. Thank you to all the participants for patient listening. We'll conclude the session now.